All right, guys, I think we're going to get started. So this is talking about integrating advanced practice providers, including both PAs and MPs, into academic emergency departments. So if you're here, you probably already have some interest in the topic, hopefully, and you probably know that although both groups, both MPs and PAs, started in the 1970s, it's really been in the past 20 years. There's been a huge increase in APPs working in emergency departments. So, for example, in the mid-90s, about 2% of patients in EDs were seen by APPs. About 10 years ago, it was 6%, and now we're up to 12 to 15% of all patients seen in EDs are seen by APPs. And this is something that I don't expect to change, and in fact the trajectory will probably continue to go up and get steeper as there's a shortage of EM physicians, especially in underserved areas. So I anticipate that this will continue. I will say one of the unique things about APP education is that it's really very much team-based. And I think they get a general education, but then a lot of the specialty education is done on site. And there are residencies, and you'll hear today from 4 different programs. Some have residencies, some don't, and they're just different approaches. But the residencies are not standard, and there are, in 2017, I think there were 120 graduates from EM residencies, which obviously is not enough to staff all the ED needs. So there is variation. There are multiple ways to do this, and we will give you some examples of the ways we have. But I think that we as physicians need to start thinking about APPs as part of our team. And I think that academic emergency departments are really well suited for this because we, for 2 reasons. One, we've always seen ourselves as training the physicians who are going to be taking care of the patients out in the world, who are going to be the medical leaders in the country. And I think maybe we should start thinking about we are the people who are going to be training the clinicians who are out there in the country and taking care of patients and leading medicine. And I think that we are perfectly suited for this because we already have an infrastructure set up for this, right? So we do bedside teaching with residents and medical students all the time. It's set up, and to add APPs into that is actually pretty easy. You're just adding more people into an infrastructure that already exists. And then adding didactics again, these are areas that we have created already for other groups and can be adapted very easily for APPs. So, as I said, we are going to give you 4 different examples of EDs who've integrated APPs into their workforce. And we all have challenges, and we all have things that have worked well. So we encourage you to ask questions and take what you can from it, I guess. So, hold on, let me get my timer. All right. So my name is Liz Temin. I work at the Mass General Hospital in Boston. Our hospital is old and big, and we do a lot. There you go. Our emergency department, we see about 110,000 patients per year. We have 58 faculty. We have 60 residents who are shared between MGH and the Brigham. And we have 40 PAs and 25 MPs who work full-time with us. For the sake of this talk, I'm going to talk primarily about our PAs who are hired into our emergency department, whereas our NPs in general are hired to work in our observation unit. I took over as the medical director for the NPs 2 years ago, and I'm working to integrate those groups, but they were hired under different job descriptions, so it takes a while to do that. So this is a really interesting slide. So when I started the PA program in 2009, we had 5 PAs, and we currently have 40. And as you can see, we now see the PAs see over 50% of all patients in our emergency department. So our emergency department is divided into a fast track area, we have our high acuity area, and then we have 2 kind of middle acuity areas. And we have PAs in all of those, and our APPs in all of those. We do not have them in our pediatrics and in our psychiatric EDs. Now, the trajectory looks very steep. but it's interesting that in terms of actual numbers, our residents, our EM residents, actually the numbers of patients that they've seen over the past 10 years is actually remarkably constant, but the percentage is less, and the percentage of PAs seeing patients is more because they've compensated both for off-service residents who have left the ED and also for our volume increase. We have on average about an 8% volume increase per year. But as you can see, they are now indispensable to the workings of our department. A couple of kind of preliminary specifications. All of our patients are seen by an attending, so our APPs do not have any independent work. This is because our APPs and our residents work side by side and sign out to each other quite regularly. So if someone was seen by a PA and then signed out to a resident, if no attending saw them because a PA saw them, now 5 hours into their course, an attending would have to get involved, and it's just way too complicated. So we made the decision at the beginning to have an attending see everyone. As I said, PAs are in, or APPs are in all areas of our ED, and they can do all procedures. In discussion with the residency, we do not have them do intubations and chest tubes, and that is because purely a numbers game, that the residents need to have those for the credentialing of the residency, but everything else we have enough numbers. And so the APPs are encouraged to take care of their patients fully, including all procedures. The financial implications are just a total and utter disaster, just exceedingly complicated, and I will just touch on that very, very briefly, but it's something that everybody kind of needs to figure out within their own hospital. So, you know, when you bill, the payers will reimburse you. There's a facility fee and a provider fee. The facility fee is going to be the same because you're in the same hospital, but the provider fee can be very variable depending on where you work, what the negotiation was with the payers, and which payer you're talking about. So for example, Medicare and Medicaid will reimburse the hospital 85% of what a physician makes if an APP sees them alone, and that's on a regional rate. Blue Cross and Blue Shield will reimburse the hospital 85% of the state rate, but the hospital can then negotiate an enhanced rate for physicians, but the APPs are not eligible for that. So it is a lot of math to figure out where the financial benefit is for your department about whether APPs can work independently or whether they should be all shared visits. So our leadership structure that we created when we first started, it was just me as a medical director and an administrative director. And then as we've grown, we have grown the leadership as well. So we have a chief, we have a director of scheduling. These are all PAs or MPs. We have student services, and I will go into the PA and MP 2 and 3 process as well. So one of the really key things is we hire a lot of new grads, which is unusual, I think, for many emergency departments. And we have a pretty stringent orientation process. So they meet with all kind of key department leaders. They do a day of simulation cases, of ultrasound training, of procedure labs, and then they spend 4 weeks where they're put on as an extra person. So they're paired with a senior PA, and I encourage them to see 1 to 3 patients at a time, and they learn, how do I admit a patient? Where's radiology? Where's the bathroom? Like the important things. And then at the end of that, they can hopefully know the logistics and can concentrate on the medicine going forward, and that will hopefully have much less of a slowdown. And they start in our lower fast track and one of our mid acuity areas. And then usually when I do their 90-day review, they can start in the other kind of middle acuity area, which just has a much higher pace. I'll also say that that for all my reviews, I solicit information from our entire attending group. I cannot work with 40 PAs all the time, much less 25 MPs who are upstairs in our observation unit as well. Fortunately, EM physicians are not a shy and retiring group, and so everybody is very forthcoming with feedback, which is exceedingly helpful. But our education, our orientation is kind of on paper is a month, but actually really goes on much, much longer. So as I said, we have kind of our initial training. And then once they have finished 2 years in our ED is when they usually start in a high acuity area, and they get a whole set of training over again. They do, again, simulation cases, ultrasounds, central lines, airway training, didactics, and again, month training shifts. And then we have ongoing training. So they have rounds that happen every month, which are specific for the APPs, but they're also invited to all the residency education. They're invited to all the rounds. They're invited to the journal clubs. They send out monthly cases. The residents send out monthly cases, which are both APP and resident cases. They have one of our ultrasound attendings does once a month scanning in the ED with any of the PAs who want to show up. And I will talk about a couple specific education initiatives that we have started. So one that I am particularly excited about, which we are just starting now, is a simulation program. So, you know, one of the natures of emergency medicine is that you see what kind of haphazardly what comes across your desk. And I think there are cases that it's important that everybody feels comfortable with. So we've created a library of cases, and the APPs get one, basically a shift a year. So it's broken down to 2 5-hour shifts, 2 5-hour sessions a year over a 2-year period, and they will run in simulation all of these cases that we have created. They are paid for this time. This is necessary training on, in my mind. So they run through the same cases. We have a list of critical actions that they have to meet. And this is because it's haphazard. You may not see a lower GI bleed in 3 or 4 months, and we want to keep it all kind of make sure that you have the exposure and are fresh for it. In addition, we have a credentialing process for our procedures where, you know, there's a set of procedures that you are able to do just because you've graduated from school. And then for everything else, there is, you have to be able to do two live procedures over a 48-month period. And if for some reason you don't have the exposure to do it on a live patient, you can do it in the sim lab as well. So if you haven't done an arthrocentesis or a thoracentesis or whatever, and you haven't done 2 of them on a live patient, you can do it in our sim lab, and we'll add that into to this simulation program. We also have an ultrasound program where we've mirrored what happens with the residents. So the PAs are do a lot of the scanning in our department, and they are held to the same criteria as the residents. QI on all of their scanning is done by the Division of Ultrasound, the same way it is with the residents, and they're given diplomas at the end for each area. So they have the same type of training. Lastly, and this is kind of one area that I'm very happy with and I'm very excited about, is our PA2 or MP2 program. So they're eligible once they've been in emergency medicine for 3 years, at least 2 of which are in RED, and they get 1 shift a month of protected time to do something non-clinical, but something that benefits our department. So I think one of the reasons that we work in an academic department is not because we just want to see patients, right? Like, we could do that for more money if we went to a community hospital. But we do it because of all the other things that we can do, the research we can do, the teaching, the outreach, really setting the pace for medicine. And I think that for the APPs, they should have that same experience if they're going to stay in an academic hospital, because otherwise they could make more money in the community too. So there's a reason that you want to be in an academic world. And so this is a promotion for them. They get a raise. They write a written proposal, which is reviewed by our leadership, and they have regular meetings with the leadership and present to the group. And so some of the examples we have, so we have 4 PAs who work with our Division of Ultrasound. We have a group who work with our simulation lab. We have 1 in geriatrics. We have 2 in wilderness medicine, 1 who runs our student program, 1 who does PA education, 1 in quality and safety, who comes and, you know, is the liaison between all of the quality and safety projects that we have in our PA group. Disaster medicine, we're in Ebola something. Sexual assault. So there really are multiple areas that people can work in, and this is, I think, really important for professional development for people who don't want to just come see patients and be done, because again, as I said, you can do that for more money and probably less stress in a lower acuity place than Mass General. So it's been really successful and really important, and I think that it integrates them into the department very well. They are, as I said, at the beginning, they're indispensable to us, and they should have a say in the running of the department as well. And then our PA3 group is kind of, we're just starting, is kind of more leadership, more outreach, doing kind of national teaching, national committees and such. And then we do ongoing reviews, 90 days annual reviews, and then I track metrics. So how many patients are seen per shift, how many narcotic prescriptions and how many pills they send, prescriptive practice guidelines. In Massachusetts, you have to review all narcotics that are prescribed within 96 hours. So multiple things. And then they've started doing academic accomplishments, which I'm very proud of, but I'm out of time.